Dear friends, further to the previous presentation of Dr. Sherman, we are proud to have him again on IVF Worldwide platform, and this time he will give a talk about making sperm and eggs from skin. Dr. Sherman, please.
Okay, so my next and biggest area of work is making sperm and eggs from skin. And we right now have the only human IRB in the world for doing this. And it's a collaboration. I'm the clinical director and the fundraiser for Hayashi, Clark, and Orwig, who are just really world famous basic stem cell scientists. And we're doing the human work myself, along with my assistant, Sierra Goldsmith. And I don't know if you can see Sierra, but you should see. So she has been key to really recruiting the patients. And I'm going to talk about how how this evolved. Why would I be doing this when I'm an ovary transplanter? So I think it's an interesting story. First, Katsuhiko Hayashi in Japan is a very, very good friend, and I've been with him from the very beginning. In fact, I was there, as you'll see, when we did the first C-section to discover the two healthy mouse pups who were developed from iPS cells from the skin biopsy of their mother. Their mother had no ovary. Their skin cells from their tail were used to make oocytes, and those oocytes were then fertilized with wild-type sperm. And these babies came from their mother's skin, not from their mother's ovary or their mother's eggs. This is Amanda Clark, who is the leader in human stem cell biology at the UCLA Stem Cell Center. One reason she got that lead is she doesn't really depend upon U.S. government grants. And of course, our study doesn't depend on U.S. government grants either, so that we don't have to worry about anybody questioning the ethics of this. And finally, Kyle Orwig, who is on the basic science sperm side of this, and you'll be seeing that we can make SSCs from PGCs. He developed the technique how we can inject them into the reedy testes of a boy that had been sterilized by his cancer treatment, and they colonize and make sperm. At least in the rhesus monkey, he's shown it, and we've practiced in the human. We know it'll be able to work in the human. And I'm kind of directing the human side of this and doing all the skin biopsies and all the patient recruitment. And you can imagine there's a lot of patients that want to be part of this. So, but what originally promoted our human trial to make germ cells from skin? I just think it's an interesting story of science. Bear with me, you may want just hard data, but I want to go through this very interesting trail, this interesting story that tells you how discoveries are made if you just keep your eyes open. It all started with our first paper in the New England Journal of Medicine on ovary transplantation between monozygotic twins discordant for premature ovarian failure. Who would have thought it would have started there? But from there, we got into ovarian physiology, how ovary cells contribute to the arrest of the primordial follicles and how primordial follicles are recruited, and then the effect of mechanical tissue pressure. And from there, working with Hayashi on ovarian longevity, and finally getting into the whole issue of longevity in general related to the fact that all of our stem cells in our body that are not even pluripotent stem cells, but they all have very, very slow turnover because of this rotation. And so they're geared towards helping us be alive for longer. Anyway, all that, one thing leads to another, and you just got to follow what's most interesting. So this was Melanie and Stephanie in 2004, just approached me because they had read about my paper in 1979 about transplanting a testicle from one identical twin to another. That was 41 years ago. We did the first testicle transplant, and they were interested in doing the same thing with their ovaries because they had failed 2 IVF procedures with donor eggs, where Melanie donated her eggs to Stephanie. And again, it all was based on the fact that all the primordial follicles are located in the cortex. And if we just took the cortex from Melanie's ovary and transplanted it And this is the paper, this is the drawing and the picture originally from the New England Journal of Medicine paper in 2005. And you can see all those craters from where we thinned out the ovary tissue, where developing follicles were aspirated, and we transplanted it onto Stephanie's denuded cortex. And lo and behold, in 5 months, she was pregnant. And there she is. That's the first healthy, normal baby from an ovary transplant. They came back more than 4 years later to have frozen tissue, because we had plenty of extra tissue, frozen tissue transplanted back. And you can see that the fresh transplant was depleted, but we had no adhesions because of the microsurgical technique. And we pleated the tissue, as we explained. We transplanted it back. And there she is with her 4-year-old baby from the fresh ovary transplant and pregnant from the frozen ovary transplant. So like I said before, that was very exciting. The first case in the United States of pregnancy from frozen ovary transplant. So how did this prompt our project to make human germ cells from skin? And so far, we're remarkably successful. I'll tell you ahead of time that we already are able to make human PGCs, high quality human PGCs from skin biopsy. And those human PGCs are very young. They're the equivalent of fetal PGCs. So that has enormous significance. I'll get with you in a minute. So this was Amanda Clark working with me on this IRB. And we wanted to know the question. The reason we could get the IRB was not to say, oh, guess what? We'd like to make human germ cells from skin, because it never would have been accepted at that stage. This was 4 years ago. We wanted to know whether misallocation at the time of splitting would allow us to determine in the human embryo when germ cell specification occurs. No one knew when germ cell specification occurred, but we could figure that out in the human based on these 10 identical twins, that one of whom had normal oocytes and the other whom had premature ovarian failure. Because if it wasn't genetic or epigenetic, that would mean it had to be misallocation. And since we had the obstetric history, we could figure out when germ cell specification occurred. What if we could generate germ cells from iPSLs of the twin with ovarian failure? That would rule out an epigenetic or genetic error causing the POI, leaving the only explanation to be germ cell misallocation at the time of splitting. So just because we always had this question in our mind, when is the germ cell specified, ultimately led to our ability to have a human study to see if we can make human eggs as well as sperm from skin biopsy. So if you look at this standard chart that everybody accepts, you could discern from the obstetric records of the mother of these identical twins who were discordant from ovarian failure, you could determine from this chart whether they split at 9 to 12 days or even a little more than 12 days, or whether they split before 9 days. So I did a skin biopsy on women with POI and azoospermic men. And again, Sierra should take a bow, because she's the one that organized this. And I didn't really do it, but she took the patients to the dermatologist and arranged for the skin biopsies on all these infertility patients of ours that had premature ovarian failure in one twin and normal ovary in the other twin. And now we're doing it on everyone. It doesn't matter who they are, we're doing it on everyone. So we have a biopsy buffer, and you can see that punch biopsy is no big deal for the patient. And we put it in the buffer. And these are the original identical twins discordant for ovarian failure. We were able to get a total of 6 of them, which is just really fantastic. A total of 6 of them to agree to do this. And their names are well known because they've agreed to this. And so we're not violating any HIPAA regulations. And you can see that the first set of twins from South Dakota, one had premature ovarian failure, the one was normal. Age 39 now, because this is so many years later. This is 15 years later. And then we had the next one from Virginia, 47 years old now. And the twin with ovarian failure had leukemia, had a bone marrow transplant from her normal sister. And so it was a different kind of case. But the results from that are interesting also. And then the last case, you can see the normal twin from Minnesota. She's now 55 years old. She was a donor for her twin sister with premature ovarian failure 15 years ago. So crystal eggs were quite fertile till 46 years of age, you'll see, because Bonnie had no eggs, and yet Bonnie had 3 babies from natural conception after the fresh ovary transplant from Crystal. There she is. This is a 38-year-old ovary transplanted from normal Crystal to Bonnie, who had no eggs, and she had 3 babies spontaneously. So now the question is, can either Bonnie, who had no eggs to start with, or Crystal, who had good eggs but now is menopausal and 55 years old, can we make germ cells from these 55-year-old women's skin biopsies? Well, we can. That's what's just amazing. Both twins, originally with and without POI, were able to produce normal PGCs from their skin biopsies at 55 years of age. Okay, you're going to ask the question, what about going from PGCs to oocytes? We'll get to that in a minute. But at least we know we could generate 3 human-induced pluripotent stem cell sublines for reproductive science research. That was the basis of the original IRB, and a 55-year-old woman who was previously fertile, generating young PGCs from 55-year-old stem cells. So just think about the implications of this. So in the future, a 38-year-old woman might be better off having a skin biopsy than an oocyte retrieval for IVF. Just think about that, because these are going to be very, very young oocytes. So Stacy was born with no eggs, and Tracy was normal. She had a healthy baby from her transplant, but then she ran out of ovary tissue, and she had a frozen transplant. Now, Stacy and Tracy, both of them, the one who had premature ovarian failure, never really had eggs, and the one who had normal eggs, they both produced normal PGCs from iPS cells generated from skin biopsies. And interestingly, we don't have to worry about abnormal karyotypes because we have so many cells. We karyotype them, and we only continue to develop the clone that is karyotypically normal. That's classic stem cell biology. It's the way you do it. So we don't have to worry about aneuploidy or euploidy. So when does specification occur, PGC? Because that is the question we originally asked. It's a scientific question. I know most of the people listening want to know how we're going to be able to make oocytes in humans from the skin biopsy. But let's get to the science, because if we don't answer the science, then we will have been deficient in our whole IRB. So when does PGC specification occur? Well, if we date monozygotic twin splitting, answering our question, when does germ cell specification occur in the early human embryo, it has to be sometime after 9 days, because these women were all monozygotic, monoamniotic, indicating the splitting had to occur. And that's a very rare group, like 2% of identical twins are mono-mono. So we know the splitting had to occur sometime between 9 and 12 days. So in the mouse, it all begins here in the epiblast. And you can see those little green fluorescent cells are a tiny group of cells that are completely separated from the rest of the embryo, which is going to develop and differentiate in such a complex way into the developing fetus and the baby. But these cells are set aside. They're not a part of the embryo. And eventually, when it's safe, they will migrate as PGCs to the dorsal ridge and become either sperm or eggs, depending on whether it's a male or a female. But so what about in the human? Well, we know because of this late splitting that PGC specification has to occur between day 9 and day 12. So this is an interesting case. We didn't expect this answer. In fact, we didn't even know if we should do this case for the study. Anna, who is the recipient, had developed leukemia and had a bone marrow transplant from her donor, Rachel. And so then 3 years later, when Anna was considered cured but completely sterile, we transplanted an ovary, or that is ovary tissue, from Rachel to Anna. And Anna now has 2 babies from this transplant. Despite bone marrow transplant and uterine radiation, she had a few miscarriages, but then her uterus got bigger and developed, and she had 2 healthy babies from this procedure. But here's what's interesting: when we look at their stem cell data, let's go to Rachel first, the donor. Rachel has normal karyotype. She has normal stem cells, normal PGCs, no problem. But Anna, who had the bone marrow transplant with total body radiation, only has abnormal karyotype. We could not get a normal karyotype from the stem cells of Anna. That has enormous implications as to what's happening to the somatic cells of survivors of bone marrow transplantation. We didn't know that before. So both donor and recipient, that is both normal and POI twins, produced euploid iPS cells and PGCs. As old as 55 years, skin biopsy produced euploid PGCs, except the recipient of a bone marrow transplant produced only aneuploid iPS cells. This is a summary initially of the total number of women with premature ovarian failure that we're currently studying. And we are going to be offering this, we are offering this for every woman with ovarian failure, premature or otherwise. And also you'll find out on every man with non-obstructive azoospermia. So the next question is, what is it that determines ovarian longevity? And this is where we worked with Hayashi, and Hayashi worked with Amanda, and it was a wonderful international communication with international funding to do this. You've already seen this in my previous lecture, that we know that there is a massive over-recruitment after transplantation of primordial follicles, indicating decrease in pressure results in massive recruitment of primordial follicles that otherwise would have been arrested. And we concluded that tissue pressure was very crucial for determining primordial follicle arrest as well as recruitment. So decreased primordial follicle recruitment occurs with decreasing ovarian reserve. There's a long duration of transplant function despite very low AMH, late menopause in multipras. Why? Because they've been pregnant so much that their intra-abdominal pressure has reduced primordial follicle recruitment. And the same thing is true of the horse ovary, which is all solid ball of ovarian cortex, very dense tissue. It's the mechanical tissue pressure stress occurring in a horse ovary naturally that allows it to not have menopause until it dies and to be fertile till it dies, and allows late menopause in multips much later than a controlled population. And what controls this recruitment, this gradual recruitment, is the pressure gradient. And you can see this even surgically under the operating microscope. Now there's this tissue pressure gradient that controls the release from ovarian recruitment of primordial follicles. So now what I'm going to do is, as I told you I would do, is I'm going to skip ahead because it's too long what I have to do, and talk a little bit. Well, actually, I don't have to skip ahead that much to get to this. I'm going to go here. I've only got 5 minutes. And this is my joke. Hayashi, Japanese and way taller than me, American. He's the X chromosome, I'm the Y chromosome. And we've worked together for many years on the issue of the longevity of these eggs. But it has to do also with the longevity of all organisms. There I am with their team. And the pressure on the granulosa cells induces the dormant state in these primordial follicles, and much more dormant on the outside, the epithelial side, than on the medullary side. And that's been really confirmed using a culture in a high pressure chamber in which you're able to completely turn off the recruitment of follicles that otherwise would have gone and developed because of in vitro production of these follicles from iPS cells. And so how does pressure control primordial follicle recruitment and FOX3 intranuclear location? Because that's the genetic mechanism. Ovarian longevity and perhaps longevity. The dormant state of oocytes in primordial follicles is a basis of the sustainability of oocyte pool in the ovary, ensuring the longevity of the reproductive life in females. Otherwise, when we make oocytes from iPS cells from skin, they just completely develop. You can't stop them from developing, and they're gone in 20 days, and that's the end of it. And that's not like an ovary, which is able to last for 50 years because you have a dormant group of follicles that are held dormant by the pressure of the ovarian cortex. And if you just to reduce the extracellular matrix, FOX3 escapes, goes extranuclear, and these primordial follicles start developing. So mechanical stress is a key factor generated by ICM surrounding the follicle structure. And this increase in cellular tension results in rotation of the nuclei. No rotation of the nuclei in dormant follicles, but rotation of the nuclei, rotation of the nuclei in the dormant follicles on the ovarian cortex, but inside towards the medulla, the nuclei are static, and so they develop. You can prevent development in germ cells or in stem cells by having nuclear rotation. When nuclear rotation stops, that is when they develop. Now, I've just got a couple of more minutes, and in that time, I am going to just have a good time with you, telling you a little bit about how we're going to do this in the human. So here, I just got 2 minutes, and I'm going to show this. So you're going to say, okay, we have PGCs, but we know from all the mouse work that those PGCs cannot become eggs unless they're incubated with fetal granulosa cells. If we incubate them with adult granulosa cells, they just die. So how in the human are we going to change these PGCs that we're very proud of, these young PGCs, into oocytes? Well, we think we have 2 ways of doing it. The first way only went halfway. Yamashiro et al.'s paper showed you can generate human oocytes by incubating human PGCs in mouse fetal granulosa cells. But these are really not normal. They're not normal competent human oocytes, indicating that to really get competent human oocytes is very species specific, and you can't just incubate them in some other animal's granulosa cells. The addition of exogenous human signaling moieties is what's really necessary to program human granulosa cells. So how do we do that? We still need fetal somatogonadal cells. But once we can generate human fetal somatogonadal cells, we should be able to make competent human oocytes, just like in the mouse. So in the female, what we do is we duplicate what the fetal granulosa cells are secreting to make those PGCs. Then those generated human fetal granulosa cells can be used with human PGCs. And I'm going to jump ahead to the very last slide here, and I apologize, I'm not organized. Yeah, because I talked about the male too, but this lecture doesn't have enough time for that. So in the female now, we found we can duplicate fetal granulosa cells with growth factors easily. In other words, we can take the same iPS cells developing from skin in the woman who has POF, and we can turn them with standard growth factors very easily into fetal granulosa cells. Then those fetal granulosa cells that we develop from iPS cells separately from PGCs can be incubated with the PGCs just like in the mouse. And this is probably species specific based on Yamashiro's paper. So we know we have to do it this way rather than just using animal fetal granulosa cells. And that's what we're currently doing. And it looks very promising because it's not hard to make human fetal granulosa cells from human iPS cells. What about in the male? Well, in the male, the whole idea is to inject PGCs into the teenage reedy testes, because the teenage reedy testes is very much like the neonatal or fetal mouse testes. So in a 14-year-old human testes, we should be able to inject just PGCs and not even need spermatogonadal stem cells. And I'll show you a picture of that in just a second, which will be my final and fantastic slide developed by Kyle Orwood. Just take a look at what we're going to do. We do this in the human now, so we'll be ready to inject the PGCs into the 14-year-old boy. And we're ready to do that right now. So that's a small needle under ultrasound guidance. We make sure we're in the reedy testes, which is a horizontal structure right in the center of the testes. And you'll see in a minute, when we inject the reedy testes, you will see that we colonize every seminiferous tubule with that injection. It'll take a second. There was the injection. And now just watch and see what happens as we colonize all the seminiferous tubules. It's beginning to happen now. So we'll take the PGCs developed from the skin biopsies of these boys who were cancer patients, and then at 14 years of age, we'll inject those PGCs into the reedy testes, and we'll be able to have colonization and spermatogenesis without having to make a fetal testes. Someday we will make a fetal testes, but this is today. So, okay, I guess, thank you. That's done with, I'm finished with my half-hour talk. I did skip a lot, but I think we got the basic ideas there, and I'm ready to answer questions now.
Thank you, Sherman. You really open a very small or maybe large window to show us the future. And mainly, the question is, when do you think all this will come into a clinical practice? What should we expect? And mainly, is this going to replace, making 3D, printing 3D ovary, making sperm, making egg? Will this replace all what we are doing today for fertility preservation?
Okay, those are two good questions. First place, I think from the rate we're going at, we really should be able to make oocytes in vitro from skin biopsies at least within 5 years. I have no doubt about that. It may not be ready for human practical clinical safety trial for 10 years, but that's a guess. You never know. But in terms of the artificial ovary, it's very important. This does not replace the artificial ovary. And I'll explain to you, I didn't have a chance to show all of the Hayashi mouse studies. And thank you for your question, because I can sort of go into that now. You saw that when you do the production of germ cells and oocytes from iPS cells, those oocytes develop very, very quickly, and they're gone very quickly because there's no pressure system, there's no anatomic system. We do need an anatomic pressure system so that we can take those in vitro generated oocytes and really make an artificial ovary from them that really works, whereby we can truly arrest those oocytes in the highly more dense layer of the artificial ovary, and they can function like an ovary. And frankly, we can transplant it back into the woman and she can get pregnant spontaneously. So both Hayashi and myself, and I think we've been working on this more than Amanda, who's strictly human, but based on our work in the mouse, we think the artificial ovary will still be extraordinarily important, because that'll be a receptacle in which we can put the in vitro generated oocytes.
Good. Okay. Thank you very much for being with us again. It was a pleasure to host you on IVF Worldwide Education Platform, and we are looking forward to a few other lectures from your side. Thank you.
Thank you very much, and thank you, everyone.